introduce you to Dr. Brian Grotkow. We are so happy to have you. Thank you for joining us today.
Pleasure to be here. Thanks.
Oh, well, I've got lots of questions for you. I'm going to put you on the hot seat. But before I do, I want to tell our audience a little bit more about you. So, Dr. Grotkow is the UHealth Jackson Children's Care Chief of Pediatric Orthopedics and Surgical Services at Holtz Children's Hospital. He's also Professor of Orthopedics and Shriner's Children Endowed Chair in Pediatric Orthopedics at the University of Miami Miller School of Medicine. He is an accomplished board-certified orthopedic surgeon and researcher specializing in pediatric orthopedic and adult spine disorders. So exactly what we're talking about today. He has all the expertise for this. Dr. Grotkow also received his medical degree at Harvard Medical School, and he completed an orthopedic surgery residency and fellowships in spine surgery and pediatric orthopedics at Massachusetts General Hospital, Harvard Medical School in Boston. I have to slip in a Go Red Sox there. I don't know if it applies to you, but I have to slip it in.
I
We
like
are
the Red
so
Sox. Yeah.
thankful. We're
Yeah.
so thankful to have you today. His clinical interests span a wide range, including scoliosis, which is what we're going to talk about today, as well as anterior vertebral tethering, vertebral body tethering, pediatric spine surgery, pediatric orthopedics, congenital and acquired disorders of the musculoskeletal system, cerebral palsy, clubfoot, hip, knee, and leg disorders, neuromuscular disorders, and pediatric trauma and fractures. Now, Dr. Grotkow, we can have you back for 10 more episodes just about each one of those specialties. So thank you for joining us today. We're going to hone in on scoliosis. We might deviate a little bit, but just thank you again for your time, and we're excited to get started.
My pleasure. Sure.
Awesome. Well, let's start with just a baseline. Maybe people are listening, we hear the term, we don't necessarily know what it means. So talk to us just baseline. What is scoliosis and how common is it in children and adolescents?
So, yeah, sure. Scoliosis refers to a three-dimensional deformity of the spine. So most people think of it as a curvature when you're looking at someone, from the front, but it's actually three-dimensional where
Oh,
it
wow.
not only bends, but it twists. There are different types of scoliosis, but the about 2 to 4% of kids between 10 and 18 years of age will have scoliosis or be diagnosed with scoliosis of the various types.
Okay. Wow. 2 to 4%. Okay. What about, are there typical signs and symptoms that could indicate, and is there a certain, I guess, range of the child development that you notice this or should be looking for this signs and symptoms?
Uh, it's tough for parents to look at this sort of thing. Most scoliosis is picked up on school screening by
Okay.
school nurses, or in some states, I think that physical education teachers are trained in how to do it,
Oh, wow.
or pediatricians on well child visits.
Okay.
Certainly starting at around 10 years of age, most pediatricians will screen as part of the annual visit with the child. Will screen for scoliosis. It can happen earlier than that. It can even be present at birth. But the most common type is called idiopathic scoliosis, idiopathic adolescent, and that's probably 85% of most scoliosis. And that generally starts showing up around 10 to 12, 13 years of age.
Okay, that was my next question. You answered it before I got it out, is why do we wait to screen until about age 10? But if 85% of the cases are showing up about then, that's why, correct?
Yeah, correct.
Okay. Okay. How is it diagnosed and what tests are involved with diagnosing scoliosis?
So the screening for scoliosis is pretty easy. You do something called the Adams forward bending test, which is where with the child's usually the shirt off or pulled up, you have them bend forward and you're just looking for a deviation
Okay.
either in the spine while they're standing, then you have them bend forward and you're looking for a asymmetry of the rib hump or the lumbar spinal musculature. And that's the basic screening exam for it. If you have a sense that that is something going on, the next thing you will do is get a scoliosis x-ray, which is a long x-ray that captures the thoracic and lumbar spine, so the chest and the low back area, to look for curvature.
Okay. Now, my wheels are moving. You're saying, say they're, assessed or whatnot at school, the PE teacher, the nurse. At 10, they don't show anything. Is it possible that 11 or at 12 or at 13, they start to show things? Or if you're going to show something, are you already showing at that point?
No, not necessarily. So curves, at least the adolescent type. Now, let's go back. Let's take a step back. And
Yeah.
there's three main types of scoliosis. One
Okay.
is a congenital scoliosis, which is something kids are born with, right?
Born
So
with.
it's either a formation of a failure of formation of a vertebral element or a failure of segmentation, meaning that the spine is a series of blocks, basically, little rectangular blocks, and if they don't segment and become individuals and get complete discs between them, or if half of a vertebra or a series of vertebra don't form, then you can get something called a congenital scoliosis. Now, those are kids. You're obviously born with that. A
Right.
second type is a neuromuscular scoliosis. So kids with neuromuscular conditions, cerebral palsy, muscular dystrophy, they're at bigger risk for scoliosis for neurologic reasons. But
Okay.
the largest area is something called idiopathic scoliosis. And basically that's divided into two types. It's early onset scoliosis. We used to call it infantile scoliosis and juvenile scoliosis, and then
Okay.
standard idiopathic scoliosis, which is adolescent idiopathic scoliosis. And that adolescent idiopathic scoliosis is the one we're kind of talking about here.
Okay.
And that represents the 80 to 85% of
85%.
kids
Okay.
that end up presenting. And so in those children, you tend to, it'll start, by definition, 10 years of age or above,
Okay.
but you might not see it. And it tends to progress most rapidly during peak adolescent growth velocity. So
Okay.
peak adolescent growth velocity for girls is centered a year before and a year after the onset of periods. Right?
Okay.
Girls will usually grow for 2 years after the onset of periods. So,
Okay.
that's kind of when you're seeing this. And it is possible that nothing is noticed and 6 months later or a year later, if it's a yearly exam, then that you notice something. You say, where in the heck did that come from? And
Yeah.
it came from being there, but just not being obvious and
Okay.
accelerating during this period of peak growth velocity.
Okay. Which again, I just think is a testament to the importance of staying up to date on those well visits, right? Because the
Oh,
pediatrician is
absolutely.
checking on those things. Yeah.
Yeah.
It's easy as a mom to be like, oh, we're behind. Well, but like, let's stay on those because there's things I kind of have the tendency like, well, after they're little babies, what more is going on? But there's a lot going on. So we got to stay up to date on those. Are there any other symptoms that you as a parent would notice after, again, they've had a clear check and then maybe later, like, is there I don't know, posture things or stuff that you would actually notice?
Yeah, you might see some posture things. One of the big things people notice is shoulder asymmetry, where one shoulder seems higher than the other, or that there's a prominence of the ribs on one side when they see their child in the bathing suit or something on the beach. Especially in
Okay,
Miami, these kids spend a lot of time in bathing suits down here, and
that's right.
it may be something you notice. It's generally, interestingly, not associated with back pain or anything like that. So don't
Okay,
expect back pain to be a big component of this. In fact, back pain and scoliosis, at least this type of scoliosis, is really not. They don't
not
run
related.
hand in hand. It's
Okay,
usually something else like muscular or something along those lines.
creating
But
that pain.
that's kind of what you might see. Um, um, yeah, pretty much that's it.
Yeah. Okay. Stay up to date on those on those well visits. That's our takeaway right here. Okay, so we talked about the three different kinds. What about when is treatment necessary for scoliosis and what are like common options?
So again, I think we'll probably focus this discussion mostly on adolescent idiopathic scoliosis because it
Okay.
is the most common type, because it really is different based on which type it is. So early
Okay.
onset would
Great.
be a lot different. So the treatment, generally, there are three forms of treatment for scoliosis. One is observation,
Mm-hmm.
one is bracing, and the last is surgical.
Okay.
And so observation generally is done for curves that are up to about 25 degrees. You just sort
Okay.
of keep an eye on them every 6 months or so with x-rays and physical examination. If someone's still growing and they have a curve that's over 25 degrees, and that again is a little subtlety because it depends on how close they are to the end of growth. You may
Right.
wait till 30 degrees, but between 25 and 40 degrees is when you may institute a bracing program.
Okay.
Braces are not effective in curves over 40 degrees, and they aren't effective in kids who've completed growth.
Okay.
So it's
Can you,
something.
I'm sorry to interrupt you, but can you stop right there? This is a question we got from our audience too. When they're stopping growth, you said, for a girl, it's the year to 2 years after the period. Can you kind of give us a ballpark of the ages for boys?
So most girls stop growth at around 14, most boys at around 16. But
Okay.
if someone's being watched for scoliosis, we get this thing called a bone age in the hand, and it
Okay.
helps us determine, when they're done growing. And so what we use most often in scoliosis is something called a Sanders classification, and
Okay.
it's graded from 1 through 8. And when people are at Sanders 8, they're fully mature and done growing.
Oh, wow. Okay.
And that's how we determine, the residual growth.
Okay.
So we were talking about bracing a little bit. And
Yes.
then
Sorry, I
the third
interrupted you.
option is, no, that's right. The third option is surgical, right?
Right.
So generally bracing is not effective at curves over 40 degrees. And
Okay.
so if you have a 40-degree curve in someone who still has reasonable amount of growth left, you're going to start thinking about surgery. We know that the data is pretty clear now that 45-degree curves, once you're done growing, will progress at about a degree a year after the end of
Oh,
growth.
wow.
So your target with all of this is to try to keep a curve below 45 degrees at the end of growth.
Oh, wow. Okay. And so when you're talking about that curve, you're not just talking about this. It's all the three-dimensional ways,
Yeah,
correct? Okay.
correct.
Wow. Fascinating. Okay, let's talk about technologies. Are there any, I mean, I hear you saying surgery, bracing, watch it. Are there any new technologies available for treating scoliosis?
There's always new technologies coming
Yeah.
along. Like let's start with bracing. I mean, there's smart bracing technologies where sensors are put into braces now. So bracing is about 58 to 60% effective in controlling curve progression in an
Okay.
idiopathic adolescent curve. So it's not 100%, right? That's
Right.
60%. So 6 out of 10, you'll keep the curve from progressing. What we mean by effective is keep the curve from progressing uh, 5 degrees or more. So keep
Okay.
that loss of
Not
progression. So
straightening it necessarily. These braces aren't like
exactly,
straightening, they're just keeping it from curving more.
from getting worse, right? And a lot of the bracing literature predates sensors and braces. So we found that kids were telling parents or telling doctors that they were wearing their brace 23 hours a day, and in fact they were not.
Right.
They as soon as they went in the room at night, it came off, and it's at an age where parents are trying to give kids privacy and everything like that, or they're
Yeah.
supposed to wear it to school and it ends up in the locker, and so it's not being worn. So sensor monitoring has been initiated. There's also 3D brace printing technology.
Oh,
Both
wow.
of these, neither of these things has been definitively demonstrated to, medically to have an improved outcome over the other things we're using now. But they're fairly new and in their infancy, so we don't
Yeah.
necessarily have that data, and people are looking at that. There's also mobile apps like everything else, where
Yeah. Wow.
posture tracking apps for people who have postural kyphosis and stuff. And there's also telephysical therapy, right? With the one thing COVID did give us was a lot more online options for
That's right.
treating patients. And a lot of people talk about treatment of scoliosis, at least while the curves are relatively mild, with something called Schroth physical therapy. And Schroth physical therapy is the jury's out on it, but there are apps that allow telephysical therapy for Schroth physical therapy, because one of the things behind Schroth physical therapy is you have to do it a lot. You kind of
Yeah.
have to do your therapy every day to make it work. And so those are some new options. There's also new surgical options, including
Oh, wow.
one that's not necessarily super new at this point. It's probably about 15 years old, but it's called the magic rod. It's a magnetic growing rod. So in kids who are like young, that you don't want to do a definitive spine fusion, and you can put these rods in, and then every 3 months or so expand them using this external magnet, sort of
Wow.
to try to correct the curve. There has its pluses and minuses, right? For instance, the power of the motor, that's basically a magnetic driven motor, are not super great. So,
Okay.
we have mechanical growing rods, and this was designed as an improvement on that, because those you would have to go back every 6 months, take them to the operating room, put them asleep
Actually,
through a
like
little
open them up.
opening,
Yeah. Ooh.
open them up, and then stretch it a little bit, close it up. This was designed to avoid that repeated trip to the operating room.
Wow.
There's another new technology that's surgical called ApiFix, that's by a company called Orthopediatrics. The idea is that you put in, it's designed to be a motion preserving surgery where you just go to the apex of the curve, or the concavity of the curve, and you put this thing in and you stretch it out a lot like the growing rod. But
Oh,
then
wow.
with you doing movements and stuff, it can sort of ratchet itself up a little more. And then lastly, my favorite new invention is something called anterior vertebral tether or vertebral body tether, which is a
Right.
minimally invasive, motion sparing surgery for scoliosis. But it has defined indications for it, and it's certainly not
For
not
everyone.
for every kid that comes in with scoliosis.
Wow, that's fascinating. And that's the one that you're doing this, correct? Like this is work that
Correct.
you. Wow.
Yeah.
Wow, I have so many questions. So, okay, I'm going to keep going because I've got lots of questions for
Sure.
you. All right, well, let's talk about this is one that just popped into my head. Living in the era of technology, and we're seeing all the effects of that in so many ways. People are staring at their phone, kids are bent over watching video. Does any of that play into it, or is that totally separate?
I, you know, I don't think our incidence has gone up since people got
Okay.
smartphones.
Okay.
So I think it's probably unrelated. There's another issue that parents always bring up is, and then I'm sure someone will, unless I head it off right now, is that do the heavy backpacks that these kids carry
Oh, okay.
contribute to scoliosis? And the data on that is pretty good at this point that it doesn't.
Okay.
Carrying the
Good.
heavy backpack does not make your scoliosis worse or anything
So
like
keep
that.
up the homework, kids. You
Yeah.
can't ditch the
Yeah,
books.
that people are going to electronic books anyway, so we'll see that as a thing of the past, I'm sure.
That's funny. Well, if you get a note from school that says we're going to iPads because of scoliosis, we're like, no, we're going to call your bluff.
Yeah,
Okay, you talked about during growth spurts. Can it worsen during these growth spurts, and how is that monitored?
that is when it tends to worsen, right?
Okay.
The scoliotic curve responds to growth hormones and everything the same way the rest of the body does. And if you have a curve like this, is that the curve will that's when they tend to get
To
tend
get
to get
worse.
bigger. It doesn't mean that they do. Unfortunately, we don't have any crystal ball at this point to predict who's going to have more of a progressive curve. Now, there is some work. You asked about new technologies. There is a lot of work, like every other aspect of the world, where AI is trying to be used for predictive purposes of who might have a progressive curve. But
Right.
that's really, really within its infancy.
Yeah. Excuse me one second. I just had my little one just popped in. Can
Oh,
you go to daddy? You want to say hello and go to daddy? Okay, she's asking if she can have a snack. She can say hello.
hello.
All right, go to daddy. Go to daddy. Take it to daddy. He's going to help you. All right, hon, can you come and get her, please? So sorry.
That's all right. This is what it's about. It's all about kids.
Here we are. This is real life. This is how it goes. Okay, we talked already about treatment options such as bracing, physical therapy, and how effective they are. We're going to get more into the VBT, which you talked about, but just recap me one more time on the bracing versus physical therapy and how effective they are. Again, we're not trying to straighten it, we're just trying to keep it from getting worse, correct?
Yeah, you're trying to, so that once you discover scoliosis, generally the goal is to keep it from getting worse, not to get it perfectly straight. I mean, kind of the only way you can get it straight is with surgery, right?
Okay.
And even then you might not get it perfectly straight because the spinal cord itself dictates the amount of correction that you can provide any given patient because it
Okay.
doesn't like being stretched, that's for sure.
Here's a
Um,
question I have on that. We're talking just about I'm not going to say it correctly, but the adolescent one of the three types. And
mhm.
if it's just curving of the spine, is it only, I guess, physical? Like, does it start to have neurological effects at that point, or is it just physical limitations or?
So the thing about scoliosis is that it's certainly a cosmetic thing, but that's the low part of it. Is that the reason that we even intervene in scoliosis is twofold, right? A thoracic curve, a curve up near the lungs and everything, have been shown and known for years that as those get bigger, specifically, you know, the best data I know of is that when you do pulmonary function tests, if the curve gets above 72 degrees, you start having measurable decrease in pulmonary function.
Oh, wow.
As the
Could never
curves
think.
get bigger than that and a little over 100 degrees, then you start having some clinically, apparent limitations like, breathlessness going upstairs. And so what happens is those curves get bigger, the heart has to pump against a bigger resistance in the lungs, and you ultimately over time, the heart is a pump just like any other mechanical pump, and it'll wear out if it has to keep
Mhm.
pushing against higher resistance. So people who have progressive curves can get into a right-sided heart failure type situation, congestive
Oh,
heart failure. People know it as congestive heart failure, right-sided heart failure, where the
okay.
heart just sort of is a pump and it wears out because it just has to do more
Just
work
having that
over
pressure.
time.
Okay.
Right. So the idea here is that you don't let that progress so that you don't get that extra stress on the heart. So that's in the thoracic spine. In the lumbar spine, where some of the curves we see in the lower back, as
Okay.
they get bigger and as you get older, you can imagine that the discs are like little shock absorbers between the vertebral bodies. And if they're like this, the ones on the inside of the curve here wear out faster,
Yeah.
just like shock absorbers in your car would wear out faster
Hmm.
if you had a big load you have a pickup truck and you're constantly carrying around 20 engine blocks in them.
That's right.
It's going to wear out, and it wears out faster on that side. So what's the big deal about wearing out? Well, then that's when backs become painful over
Yeah.
time.
Nerves and
So
stuff,
even
right?
though it's not associated with pain, I told you that in adolescence generally it's not associated with pain. As you have this adolescent curve that has gotten bigger and progresses into adulthood, 40 years of age and stuff, then you're going to get disc degeneration, asymmetric, and that's when you start getting pain. So in the thoracic spine, we're worried about cardiopulmonary function. In the lumbar spine, we're more worried about discomfort.
Okay, that makes sense. That's so helpful. Thank you for explaining all that. That was, you kind of think, where are we going long term with this? So that's really helpful to know the why behind the what of what they're doing at that age. So let's talk about now the VBT, vertebral body tethering, and how does it differ from the traditional spinal fusion surgery?
So vertebral body tethering has a number of names. It's new enough where people, I like to call it intervertebral tethering. Some people
Okay.
call it anterior vertebral body tethering. So you'll see it called AVT, VBT, AVBT.
Oh, wow.
So
Okay.
we
All
haven't
the
quite
same.
decided on the name. Yeah, it's all the same
Y'all need to
procedure.
get together and have a think
So
tank and say, let's
we're
choose
trying
this.
to, but there's some egos involved, like anything else. So um, you know, what it is and the way it differs from a standard spine fusion. What a spine fusion does is it takes screws and rods. It takes screws, put screws into the bone down these things called pedicles, and then
Okay.
you connect them with rods, and then you loosen the spine up a little bit. You twist them, and you basically convert a flexible spine into a rigid, almost like a femur bone, a thigh bone, right?
Okay.
And then what that does is it kind of robs the spine of its function, which is to be
Autonomy
able
to
to
twist
move
and yeah, but
and allow you, mobility and stuff like that.
okay.
What anterovertebral tether does, AVT does, is it's a motion sparing procedure, and it's much more minimally invasive, right? So if we're taking care of a thoracic curve like I did yesterday, day before
Ah,
yesterday, the curve, a traditional scoliosis operation is done through the back, through a long incision in the back. You have to expose the spine and put in all these screws
wow.
and rods.
Wow.
The intervertebral tether, if you're just dealing with a thoracic curve, can be done through, is the way I do them, through three little 1-inch incisions, sort of just along the lateral side. And we use a scope, so that you
Wow.
can visualize everything with the scope. And you work through these three things to put these little anchors in bone. And then instead of putting a solid rod in, you put a nylon cord in, and it's made out of it's
Wow.
PET, polyethylene terephthalate, but it's like a high density climbing rope. Bless you, high
Thank
density
you.
climbing rope that you might use on Mount Everest. And then instead of
Wow.
doing this compression and distraction that you do with fusions, what you do is you basically play tug of war. You fix it and you tug of war between one vertebra and the other, so that you go boop 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 boop, and you correct the curve. And the beauty of it is, if you have a lot of growth remaining, let's say you're doing this in a 12-year-old or something who has a lot of growth remaining,
Mm-hmm.
that's not the end of it. It's what we call guided growth. That can then continue to influence the curve into continued progression, because bone is interesting in that it 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 slows growth when it's compressed, and it grows faster when it's rarefied or distracted. So
Okay.
you've got this curve that you corrected. This side that you've corrected is under compression, so it grows relatively slower than the other side, which is relatively under distraction. So that you'll
Right.
see with time some increased correction of the
Wow.
curve. And so in that sense, it's called guided growth. But the
Okay.
beauty of it is that
Wow.
it preserves the motion and function of the spine, as opposed to a fusion, which sort of takes away that motion and function.
Right. And a fusion is like, I mean, it's fused. So it is what it is, right?
Yeah, the fusion is the end result. So that's the other thing about AVT. You can't, you could always do a fusion after an anterovertebral tether, but you can't do an anterovertebral tether after a fusion.
After a
That's for sure.
fusion.
Yeah.
Makes sense. Makes sense. Wow. Okay. Did you discover this or are you on the cutting edge of the developing of this?
I'm one of the people that does it the most. No, the guy who discovered this I hired him back when I was in Boston.
Wow.
A guy named John Braun. He came up with the idea 20 some odd years ago, originally. And, it's FDA approved. Although if you talk to the insurance companies, they say, it's experimental, but it's not. It was FDA approved in 2019.
Wow.
And it's a really, I think, a good idea. Is it the be all and end all? Is it the final word on scoliosis? No, probably the final word will be something genetic, where you can
Yeah.
replace some sort of a gene that has yet to be discovered. But everything we've done in orthopedics that has been aimed at preserving motion has been a big success. When people had hip arthritis in the early 1960s,
Right.
were debilitated by that. The hip was fused, it was made solid, took away the pain. You walked with the limp and everything, and it gave you limitations. Same with knees, right? Knee
Right.
replacements and
Knee
such. You
replacement.
used to fuse the knee to take away the pain. When Charlie first started doing hip replacements back in the late 60s in England, it preserved motion, took away pain. And hip replacement right now is the number one operation for improving quality of life years in all of medicine, right? Not just in
Wow.
orthopedics, in all of medicine. So that I use that kind of as my paradigm. Things that are designed to improve motion
Yeah.
generally have better long-term outcomes for patients. Excuse me.
Wow. So can this tethering technology be used in other parts of the body too, or is it
We
unique to?
do use it in other parts of the body, not so much
Okay.
as tether, but we use the concept of guided growth in other parts of the body. For
Okay.
instance, if a
Okay.
kid comes in with bad, knock knees or bowed legs or something like
Uh-huh.
that, what we'll do is we'll put a little plate on the side of the growth plate. So if you have bowed legs, I did this last week actually. If
Wow.
you have bowed legs, you can put a little plate across the growth plate, and it tethers the growth on that side, so the other continues to
Wow.
grow. And then once you get it back to the position you want, you can take that plate off.
And
And
then
as long
just
as it's been less than about a year and a half, growth resumes at the normal. So
fascinating.
we are using it in other parts of the body, and that was sort of the impetus to come up with this. Is that,
Oh,
listen, if
wow.
it works in these places, why
Why not
can't it
right here?
work in the spine? Right.
Wow. Fascinating. Fascinating. Okay, so tell us potential benefits. I mean, you spoke to some of them, but are there risks also? You said it's not the end all be all. So tell us about risk and benefits.
So there are always risks, but I actually think it's a lot safer than a spine fusion, because in a spine fusion, I told you we're putting screws down these pedicles. Now the pedicles generally are 8 millimeters and less in diameter, right? And younger kids, they're smaller. They're
Wow.
sometimes 5 millimeters or something like that. And the pedicles are the walls of the spinal canal. Down that canal, which is almost like a tunnel, runs the spinal cord. So you're threading these little pedicles and putting the screws in. Now, listen, we can do it safely. I mean, not even a perfectly done operation has its complications, right?
For
So
sure.
potential
For sure.
complications. So, but I personally have put in more than 10,000 pedicle screws. I think I can, certainly
Wow.
do them very, very safely and everything. But when you're dealing with the anterovertebral tether, the vertebral bodies are about an inch by an inch, in terms of size and square,
Wow.
and it's well anterior to the spinal cord. So the spinal cord's back here. So you aren't really, playing around the walls of the spinal canal. So I think the neurologic risks are lower, right?
Yeah.
You're doing it through like I said, at least in the thoracic spine, through a thoracoscopy. So there's less muscle dissection.
Amazing.
You do deflate the lung so that you can get to it, and then you reinflate the lung. So
Whew.
there's a risk of pneumonia and stuff like that in both types. But I think generally the risk profile for an AVT is a lot less than it is for a fusion, and
Okay.
the recovery is a lot faster as well.
That
Like
was my
kids
next
will
question
usually,
is what does the recovery look like? Yeah.
yeah, well, so it depends on what you mean by recovery, but let's just say I'm going to break it down. The hospital stay is usually
Yeah.
2 nights. You go home the morning of the third day for an
Okay.
anterovertebral tether. Blood loss. Our average blood loss, I think, in our over our first series of patients was around 30 cc's for a anterovertebral tether, and it's about 250 to 500 cc's for a spine fusion.
Oh, wow. Wow. So it drastically brings that
Yeah,
down.
but we generally don't have to give blood transfusions for the spine fusions cell, but we
Okay.
do use something called cell saver, where we wash the cells and give them back to the patients because it's a
Wow.
significant enough, but we don't have to do that with the anterovertebral tether. The Generally, kids who have spine fusions are out of school for about 6 weeks because it just saps a lot of energy from them.
Yeah.
Most of the kids with anterovertebral tether are going back to school at about the 2 week point. We
Okay.
let them start participating in sports around the 6 week point, but non-contact sports, so
Right.
not like
Not football.
collision
Yeah.
sports. Yeah,
Right.
yeah, or rugby or whatever.
Yeah.
And then, but generally at around the 3 month point, we will let them spine fusions, about 3 months for the beginning of participation in non-contact sports, and about 6 months for contact sports, depending on how many levels you had to fuse. So that's what I look at in terms of recovery.
Okay. Wow. So is there a certain type of patient that you're like immediately like, oh, you're a good candidate for this. This is the best suitable treatment option.
Well, it's not immediate. You have to do a number
Okay.
of imaging studies because I published a paper earlier this or last year, so in 2024, looking at our first 10-year experience with the anterior vertebral tether.
Wow.
And I I think that was the paper. We put out a few, but I'm pretty sure it's in that paper that we defined 3 ideal criteria for anterior vertebral tether. And one of the criteria is that you have a flexible curve, right?
Okay.
Well, actually, I'm going to start at the size of the curve. The curve between 40 and 60 degrees.
Okay.
40
So
and
a
60.
significant curve. Yeah.
Yep. One is a flexible curve, one that corrects at least 50% on side bending x-rays, or what we call bolster views, right? And
Okay.
the third ideal indication is that you have residual growth remaining in the spine, right?
Okay.
So those aren't absolute indications, but they're just ideal indications. And we found that if you had 3 out of the 3 ideal indications, there was a 100% good to excellent result with the anterior vertebral tether.
Wow. That's amazing.
If you had 2 out of the 3, it was 90% or 89%, right around
Wow.
90%, good to excellent results. If you had 1 of the 3, you had about a 60%, 58% good to excellent result. If you had 0 out of the 3, you had a 0% good to excellent result. So, so,
You need
so
at
the
least
bottom
one to
line,
have favorable. Yeah.
correct. And we're redefining those more and more as we have more experience and longer follow-up and things like that. For
Mhm.
instance, we find that we may be able to take care of curves above 60 degrees if they're more flexible. For instance, we
Okay.
usually look for 50% flexibility. Our latest data, which we haven't quite published yet, I think we've submitted it, but so you want about 60% correctability of a curve
Okay.
that's above 60 degrees, probably 70% correctability of a curve above 70 degrees, right?
Okay.
To make it favorable. So we're constantly refining the criteria with who's the ideal candidate.
Wow. And okay, one of those three you mentioned that there's still room for growth. So does that mean, based on what we talked about, boys and girls and ages of growth, that like these surgeries are mostly happening on children under 16 or?
Yeah, mostly. I mean, I've done people up to 25 years of age who have a
Yeah.
flexible curve. So it's not an
Okay.
absolute indication. In
That's
fact,
just
the
one of those things.
FDA doesn't look at it as an absolute indication. They just say, and in their humanitarian exemption approval, they said residual growth remaining, and
Okay.
clavicle growth plates are the last to close, and
Oh,
they
wow.
close at around 25 to 26 years of age. So
Interesting.
to me, the most important factor is the flexibility of the curve as to
Okay.
where it's, who's going to be a reasonable
A good
candidate for it. Now,
candidate.
that being said, people who come in and their primary complaint is the rib hump, that it's
Uh-huh.
prominent and stuff, or back pain, because some people do have back pain. It's not a usual feature. Then those patients generally are better served with fusion because those are better able to derotate the spine, and you can get a lot more correction with a fusion than you can with an anterior vertebral tether.
Okay. Okay. Wow, it's fascinating. So obviously you're working on adolescents, children. Is this something that are there surgeries still available and happening for, say, an adult who maybe was undiagnosed for a lot of years, or now it's really causing issues? Or, I mean, is that a thing, or is that kind of an outlier that doesn't usually happen?
Well, so most adults would, if you're having discomfort or a progressive curve, would have a fusion.
Okay.
I do have someone I know very well up in the New York City area who says that he's done intervertebral tether on a couple of 45-year-olds.
Wow.
Yeah, he said they had flexible curves and he was happy with
Very
the
flexible.
results. So, but I've done a lot of adult spine surgery and I haven't found any 45-year-olds who have curves that I
Or
think
that
would be
flexible.
a
Yeah.
candidate for this. Yeah.
Yeah. So that's a fusion. As you get older, that's fusion. So I've
Yeah.
also just the importance of staying up to date on these pediatrician visits to make sure we notice these things that, the doctors are going to find and watch by assessing our children. So Dr. Grotkow, this has been Fabulous. I feel like you have taken a very complex subject and you have, spoken layman's term for us that we could really take it all on. It's really been helpful. I have one question from our audience that just came up. It said, after the tether that says double lumbar tether breaks, what is the percentage of the curve starting to worsen or returning to the pre-surgical curve?
So in our data, and I can only speak about the data that we have, the first of all, it depends on what they mean by a double tether, right? So boy, this gets complex.
Yeah,
So
I understand if it's,
your tether breakage in the lumbar spine, the most common level for tether breakage is the L2-3 level in the lumbar spine. It's more common if you're doing an isolated thoracolumbar curve because there's a lot more motion there than there is in
okay.
the thoracic spine. But it seems to be less if you address the thoracic curve in addition to the lumbar curve. So you're doing a double tether in one day. You're doing it from one side in the thoracic spine, the other side in the lumbar spine. Now, that being said, we saw a tether rupture rate in our 10-year paper at,
Oh,
I
wow.
think we said 13%, but
Oh, wow.
only 3% of those required further surgery, right? So,
Okay.
on average, we saw when you broke a tether, an 8-degree increase in the curvature. So it wasn't going back to where it was
Where it started.
before. So
Pre-surgical.
that if
Okay.
we had a curve that we got down to lumbar spine, a lot of times you get the curves down close to zero. And so then you may have an 8-degree curve. I don't know whether it's because the uh, end plates remodel, whether your brain says this is my new position or something, but that's the
Right.
finding we have. Now, you have to remember that that's our 10-year experience, right? Spine fusion has 70 years experience behind it with
Wow. Yeah.
spine
Yeah.
fusion. So this is a newer technology. So I can't tell you where it's going to go in the next 10 years, whether that gets
That's right.
worse or not. I suspect that it's going to pretty much stay there. Now,
Okay.
the word double tether, what I've started doing in these curves whenever possible, and the child is big enough, is I've been putting tethers side by side. It's so a double tether in the lumbar spine.
Oh, wow.
And I have yet to see a breakage of a double tether.
Okay.
So, and I'm not aware of anyone who's reported on double tethers with
Okay.
breakage at this
Yeah.
point. So if they're talking about breakage of a double tether in the lumbar spine, I just haven't seen that yet. But I would
Okay.
expect it wouldn't behave any differently.
Okay. Wow. And then another question is this procedure ideal for a C curve or S curves or both?
Well, it depends again on the flexibility of the curve. So sometimes, and this is not an uncommon scenario, you have a very stiff thoracic curve. I told you the thoracic spine is not usually as flexible as the lumbar spine.
Right.
And so we started doing a number of years ago, and I think people elsewhere are doing it now, is that we do this thing called a hybrid tether, where we do a selective short fusion of the thoracic spine to take care of the stiff curve. And then in order to preserve motion segments, because your most important motion segments are in your lumbar spine. That's where you feel stiff
Right.
if you tie up the lumbar spine too much. Then what we'll do is we'll correct that thoracic curve with the standard fusion, but instead of fusing down into the lumbar spine, sometimes you have to fuse down to L4, L3, which leaves you only 2 open motion segments.
Oh,
Then
wow.
instead we do a tether below that construct to preserve, and we call it a hybrid tether.
Oh, wow.
And we'll
Okay.
be reporting on our hybrid tether outcomes over the next
Wow. That's
little bit of time.
fascinating.
We have all the
Dr.
data.
Grotkow, this is so cool. I would gotta say, one of the unique things about UHealth Jackson Children's Care and just the partnership there with the University of Miami Miller School of Medicine is that you're not just getting an MD, which is amazing, but you're getting an MD and a researcher like yourself, who you're constantly growing and deepening all your education in this. You're writing the education on this. You're doing the research. It's just fascinating. So I just appreciate you sharing all of your expertise with us today. Well, you have given us a lot to think about. I would love to have you back for another episode. I think there's a ton of other orthopedic things that parents want to know about. So perhaps we can have you back in the future. But thank you so much for your time today. I think we're going
You're
to put
welcome.
a graphic here on the screen. So listeners, if you want to screenshot that for further research on your own, you can do that. And I just want to make one quick announcement here that we have got next month's episode is going to be July 17th. That's Thursday at noon, and it is going to be in Spanish. So we're going to be talking about sleep strategies from newborn to teenagers, and it will be in Spanish for you. So join us for that engaging webinar on sleep strategies, essential topics like the importance of sleep, bedtime routines, managing sleep challenges, learn how to help babies fall asleep, stay asleep, what are the common sleep issues like sleepwalking, and how to get practical tips on how to handle nighttime waking. So whether you are navigating sleep patterns and you're newborn for the first time or you're dealing with crazy teenager sleep habits, this webinar is going to be helpful and valuable and give you strategies to ensure your child has a restful night. And it's all going to be in Spanish. So mark your calendars. If you have joined us for this one, you'll get an email notification. But as a reminder, all of our episodes, including this one, will be found on our website, which is parentalguidance.org. So you can go there, you can sign up for future episodes. You can take this episode and forward it to a friend or a family member. But again, just screenshot this for great additional resources about orthopedic. And Dr. Grotkow, thank you so much for sending your expertise with us today.